and I'm going to discuss a topic on ERCP in surgically altered anatomy. First of all, we need to understand there are many different kinds of altered anatomies in the upper GI tracts. Some of the more common cases are Roux-en-Y hepatojejunostomy, loop gastrojejunostomy, Roux-en-Y gastric bypass, BRAF2, conventional Whipple, and total gastrectomy. And some of these anatomy involved gastric resection, whereas others without any surgical resection. Some of them involved intact papillas and some don't. And finally, some lumens are much longer than others in order to reach the papilla or the biliary anastomosis. It is common knowledge that altered upper GI tract anatomy poses challenging to performing successful ERCP. And many of these factors are well known to all of us, but we can certainly go over some of them. The inexperience of the endoscopist is certainly a major factor. Some of the alterations are not done to the form of the standard operation, so it makes it confusing. The decision of navigating through the bifurcation of anastomosis is difficult. Some cases are much longer and more tortuous and fixed intestine than others. And there's uncertainty about whether you will reach the target location, and difficulty visualization of the papilla. And also, if you're using a enteroscope to perform ERCP, these scopes are floppy, have frictions, and have lack of elevator, and can require long accessories to perform the procedure. Now, not all of the altered anatomy ERCPs are difficult. Some are relatively easy, such as post-Whipple or partial gastrectomy, and some are intermittently difficult in terms of the length, such as the loop gastrojejunostomy, Roux-en-Y hepatojejunostomy, or total gastrectomy. The real difficult ones are the ones that involve Roux-en-Y gastric bypass surgery. And of course, the duodenal switch type procedures, we should not even try to perform ERCP in these cases. But just like conventional ERCPs, good training, good experience will get you there and become successful. There's some general guideline that you need to follow, such as being familiar with the common altered anatomy, so you know how to go from point A to point B. You need to acquire the basic skill in performing enteroscopy. If you are doing a enteroscope type ERCP, you need to have all the accessories available at your disposal, and you need to know how to enter a anatomy correctly and how to find a major papilla or the biliary anastomosis. And most important of all is to be able to practice just like any other ERCP procedures. In performing these type of procedures, one of the first things you need to do is to keep the scope straight and minimize the air insufflation, especially if you're going to use a shorter instrument, shorter scope, such as duodenal scope for BRAF2 type procedure. If you distend the scope, if you allow the tortuosity to take place, then it will be much harder to reach the proper location. If you're doing a duodenal scope for BRAF2 type procedure, you have to watch out for these fixed angulated area, because the duodenal scope has some blind spots, and during the maneuver of negotiating around this area, you can perforate the lumen, the angulated position. In fact, 5 to 18% of scope induced perforation is the risk quoted in passing duodenal scope through BRAF2 type anatomy. And so when you're using a duodenal scope to navigate through these altered anatomies, you need to make sure that you can see your lumen well and reduce the speed of passage, reduce sudden rotations, make sure there's no excessive air insufflation, and you have to shorten the scope frequently to reduce to minimize these risks. And also, some of these anatomies, especially Birov-2 or Whipple, have these additional lumens to bypass the afferent and efferent limbs called the Braun procedure that allow additional permutation of passing the scope to different lumens, different way of passage. So you have to be able to keep track of where you're going. Now, when passing the duodenoscope through the Birov-2 type anatomy, I like to keep the lumen at the 6 o'clock position, much like you're driving a car through a tunnel. And so 6 o'clock midline is always important, and minimize the air insufflation and pushes only gently and always shorten the scope intermittently. Very, very, very little rotation is needed. Again, this is one of the ways of doing that. You can see very slow, deliberate movement, keep the lumen at 6 o'clock, and so forth. Some of the general tips of performing a successful enteroscopic ERCP, if you're using the enteroscope, is to keep the scope straight. Again, minimize insufflation. Slow down when you're near the anastomosis of the bifurcation, and use fluoroscope to help you to know where you are and how to pass the scope. Cannulation takes special skill. You need to know how to place the papilla, and you need to orientate it well and use a cap to help you stabilize the papilla for cannulation, and use the right accessories. And also, you have to be able to perform synchronymy, balloon dilation, and strong extraction even after you get into the duct. Now, one of the first challenges in passing this anatomy is encountering the bifurcation. So one of the general rule of thumb on passing this is to find your anastomosis, which is usually the staple line usually arranged like a circular defect. You can see, like in this case, once you trace the full circumference of the staple line, then you can you need to go across the staple line, and usually you go to the lumen closest to the staple line, or if you have 3 lumens in series, you usually have to pick the middle lumen, which is usually the afferent limb. In this case, it's similar, but a little bit harder to see the staple line, but it's the same idea. Not all the anastomosis are difficult. The Whipple cases are quite easy to find your lumens because, one, you have only 2 lumens instead of 3. Second, the afferent limb is usually predictably at the top and to the left side, so it's like around the 10 o'clock position. And roughly 90% of the time, that's the orientation you will know that's the afferent limb. If you see bile in a small bowel lumen, you need to slow down your scope because you're getting very close to the JJ anastomosis. Sometimes the JJ anastomosis is very easy to miss, and you end up zooming past it, and then you regret passing long length later without knowing whether you're going to reach the papilla or the bile duct anastomosis or not. Don't be fooled by seeing a lot of bile collecting in a lumen, because many times people think that it is the afferent limb, but it's not true. It's actually, you can equally see a large amount of fluid in the efferent as it is in the afferent limb. But if once you've seen the bile, if you don't see the anastomosis after going a distance, you know that you passed the anastomosis. You probably need to come back and find the lumen again. One of the most difficult cases of doing enteroscopic procedure is to not knowing whether you have reached too far into the efferent limb and need to come back. That is a something that you have to acquire the skill and the feel for that. At the same time, there are some general rule of thumb. You need to know you have to be willing to come back at times, and leaving some marking on the mucosa is very helpful, such as performing some biopsy on the mucosa would help you knowing that you're not going back to the same limb, or you can put a guide wire through the existing lumen when you come back, so that you don't go back to the same lumen. Now, do not use tattoo, because tattoo would make it permanent ink and confusing you in the future if you need to go back, assuming that it may not be the right lumen. Take advantage of the fluoroscopy capability is very, very helpful to know where you are and straighten out your scope. And also, frequently, if you're in the right upper quadrant, you know that you're very close to the biliary anastomosis or the papilla. Sometimes you can also see the outline of air, then you know that you are at the hepatogenostomy. Some of those stenosis are so difficult, you can only blindly pass a guide wire, and this would help you by knowing where you should try to do so. If your scope is in the right lower quadrant, the chances you're in the wrong place. Or you can put contrast in, diluted contrast, and you can tell that you're in the efferent limb or afferent limb, like in this case. You can also look at the gas pattern and know where you are. And if you are dealing with an intact papilla, using an endoscope, you want to keep your endoscope very close to the papilla at 5 or 7 o'clock. If you're doing a duodenoscope, the opposite is true. You want to put the papilla at the rooftop of the lumen, and you want to cannulate from distance. Whereas if you are dealing with a endoscopic cannulation, then you want to be very close to the papilla, such that you can get it about easily. Using a cap on these endoscopes are very helpful in visualizing the papilla and navigating around the lumen, but also help you secure the papilla for cannulation. It is often said that you don't have enough accessories for the long endoscopes. The fact is, we have plenty to work with, such as in this case. Here is a example of the video of a actual procedure. You can aspirate the papilla into your cap, and now you can take your time to cannulate the bile duct. It's not always that easy, but sometimes it is that easy. On the other hand, if you're dealing with the pancreatic duct, frequently you would need to do a retroflexion within the duodenum, such as in this case. But be careful when you're doing this maneuver not to excessively push your scope, because you can cause perforation that way. This is my favorite go-to instrument, long 320 single lumen catheter for cannulation. I use the guide wire as a lead to cannulate the papilla. This is a 025 guide wire, which is thin enough to allow contrast to inject around the space in the catheter. Going over a wide side arm adapter. Having some lubricant using vegetable oil or olive oil is very helpful for passing through the long scope. If you're using this type of sphincterotome, you cannot cut the papilla because of the tangential nature. What you do is that you cut the sphincterotome and leaving a short straight wire of the sphincterotome as a needle knife, and that would be helpful with the guide wire first assessing the bile duct. After the guide wire in place, now you can take your time to cut the papilla with the cut downward at the guide wire, and eventually you'll be able to open up the opening really well. You can also perform the stenting of plastic stents, 5, 7, or 8.5 French if you're using a 3.2 millimeter channel endoscope. the various type of stent, straight or pigtails can be used and placed with this type of scopes. Sometimes you can also put the short stents in series so that you don't have to exchange the guide wire and pull instrument back and forth multiple times. Like such in this case, after you balloon dilate the benign stricture, you can put one stent and then recannulate with the guide wire and put a second stent. And finally, a third stent can be done in the same manner with the guide wire first in place and then the stent through it. Even metal stent can be placed quite readily by leaving a guide wire in the bioduct and keeping the overtube of the endoscope very close to the anastomosis of the bioduct. And now under fluoroscopy, then you can perform stenting of the various type of metal stents. Even for Roux white gastric bypass, which is the most challenging of all ERCP procedures, it's actually ERCP can be performed, but often we quoted that it is too difficult by most endoscopists. But my skepticism is that many of them just do not like to use single or double balloon endoscopes. They don't like to go for the anastomosis with the challenge of knowing which lumen to go. And they don't like to cannulate the native papilla, which is probably quite difficult sometimes, and certainly don't like to use long accessories. So many people would gladly report a high failure rate. Now, is it a misconception or is it true? Well, if you look collectively of the literature, that is true. You look at this, the balloon enteroscopy ERCP is vastly inferior to edge or laparoscopy ERCP procedures, inferior by somewhere around 30%. But if you look at the adverse event rate, the balloon enteroscopy is far superior to edge and laparoscopy, much safer. Just when people say that it's hard to do and you cannot learn, but actually you can learn. Like you look at our experience that we published, this was me after over 100 cases, had a success rate of over 92%. But my colleague who never done that before and learned how to do endoscopic ERCP, and his success rate for the first 20 cases, exactly the same as what I had. So you can actually learn to be really good at it. And no, it's not always like 50-some%. It's actually 90% success rate. Now, it's no question that there are certain circumstances which favor one or the other, and sometimes exclusively one technique over another. If your patient insists that you want one procedure done only and has the safest profile, then a endoscopic procedure is the best procedure of choice. This is particularly true for someone who have had prior gastrectomy because it wouldn't allow you to do an edge procedure or a laparoscopic procedure. On the other hand, if someone needs multiple ERCP exchange of stenting, etc., or if the patient also needs a EUS at the same time, then there's no question that edge is the right procedure of choice. Likewise, in a community setting where there's no expertise in doing enteroscopy or to perform LAMPS invasive procedure, then the laparoscopy is the best choice in doing these cases. So in conclusion, even though autoanatomy ERCP is intrinsically more difficult and challenging than the standard duodenoscopic ERCP procedure, these challenges can be overcome by using the right scope, correctly interpreting and navigating through the different anastomosis, utilizing the proper accessories to cannulate and to cut the sphincter, and to practice until you get good at doing these procedures. Just about the only autoanatomy ERCP procedure when a duodenoscope can be routinely used is Burov-2, and sometimes per Whipple cases. The rest of them need longer scopes, such as a a colonoscope or more likely a endoscope. Most autoanatomy ERCPs are actually not all that difficult to do. You just need practice and experience. Even Roux-en-Y gastric bypass ERCP can be successfully accomplished in over 90%, certainly in the case in our center. There are now faster and more invasive techniques as alternatives to the endoscopic ERCP procedures, such as the edge procedure. But these procedures should be adopted on a case-by-case basis, and only if it is deemed to be better and safer for the patient. I want to thank you for listening.